call upon Dr. Ranju Kharel, who will be speaking on specular microscopy, iridocorneal angle. Can they be the biomarkers in managing anterior uveitis?
Thank you, AIOC and Nepal Ophthalmic Society for this opportunity. So I'll be talking on specular microscopy, iridocorneal angle, and corrected intraocular pressure. Can they be the biomarkers in managing anterior uveitis? I have no important disclosures to be made. So I start that globally we all know anterior uveitis is the most common anatomical form of uveitis. It is true for our country also, where 61.8% of all uveitis fall under the anterior uveitis category. And what happens basically is, in case of anterior uveitis, there is breach in blood aqueous barrier. This leads to the release of inflammatory mediators and exudates in the anterior chamber. This interrupts the normal function of the corneal endothelium, the trabecular mesewalk. There is some insult in the ciliary body and also in the aqueous humor. So when there is breach and release of these mediators and exudates in the anterior chamber, there is the presence of these keratic precipitates in the endothelium. This leads to the alteration of the endothelial cell dysfunctions, alteration in the corneal thickness. If the keratic precipitates are very large, they go near the angle and they can obstruct the normal drainage pathway and then thereby alter the intraocular pressure. What next? The cells in the anterior chamber, the exudates and hypopyon, they can have a direct impact to the endothelial cornea, corneal endothelial cells, or they can clog at the angle, causing the outflow obstruction. Moreover, these inflammatory mediators can lead to the thickening of the iris and also the trabecular mesewalk, thus leading to the structural change. Thereby, there can be change in the pressure. The intraocular pressure can be elevated, and this can happen because of the resistance in the trabecular outflow, which is due to the trabeculitis or the morphological changes in the trabecular mesewalk causing the narrowing and decreased drainage, or because of the occlusion. Not only that, there can be reduction in the intraocular pressure, which could be due to the increased uvascleral outflow. The inflammation in the ciliary body can also lead to the reduced intraocular pressure, leading to hyposecretion due to ciliary shutdown or even because of the ciliary body detachment. And the final thing is the presence of the 360-degree posterior synechiae causing occlusive pupillae can lead to the secondary blockage, or the peripheral anterior synechiae can lead to the narrowing of the angle. So this all can lead to the change in the intraocular pressure. So we did some hospital-based comparative cross-sectional studies at the eye department of BP Koira Alliance Center for Ophthalmic Studies, where we looked at the affected eye as the case eye and the unaffected fellow eye as the control eye in cases of unilateral anterior uveitis. But in case of bilateral uveitis, we took the control eye as the eye of the healthy people. And then, which were the biomarkers that we looked for? There were 3 biomarkers. The first biomarker was the endothelial cell density, which was evaluated by specular microscopy using the NIDEC machine. Here we found that the corneal thickness, when there is endothelial dysfunction in the affected eye, the endothelial counts goes down, and this leads to the increase in the corneal thickness. So this is a representative picture where we can see that the endothelial count has gone down, because this is a case of right eye acute anterior uveitis. The count is low and the corneal thickness has increased. The next biomarker that we looked into was the iridocorneal angle. This can be assessed using the Bond-Cyrus corneal topographer, where it assesses the 360-degree angle in the angle and then gives an average of angle, iridocorneal angle, and it can separately gives the measurement of the angle in the temporal as well as the nasal end. So here we can see that the angle was narrow in the nasal part of this patient. It was only 34 degrees at the time of presentation, which later reverted after the treatment. So third biomarker that we looked is the corrected intraocular pressure. What do we mean by corrected intraocular pressure? We all know intraocular pressure depends upon the corneal thickness. So with this Bond-Cyrus machine, we can have a corneal topography, and it gives the average measurement of the corneal thickness. And this machine has an inbuilt formula, a Heller formula. So inserting that with the use of this value of this central corneal thickness, it calculates by itself the corrected intraocular pressure. This patient had a pressure of 10 millimeter of mercury, but once we inserted the central corneal thickness of this patient, the corrected intraocular pressure came to be 8.04. So it was a false high pressure, and in fact this patient was having a lower pressure. So when we evaluated this parameters, this biomarkers, we found that the corneal thickness, the central corneal thickness in the eye at the time of presentation is definitely raised compared to the control eye, and that normalizes after the treatment. This is similar with the intraocular pressure, but there is only modest change in a normal intraocular pressure. But when we look at the corrected intraocular pressure, yes, the change is notable change in the pressure before and after treatment in compared to the control eye. There was also changes noted in the iridocorneal angle in the affected eye versus the unaffected eye, and also in the same eye before and after treatment. So when we analyze these parameters in the same eye, we found that the change in the central corneal thickness before and after in the same eye was statistically significant. It was significant, but not statistically in terms of intraocular pressure. But when we use this Ehler formula and calculate the corrected intraocular pressure, yes, the change was significant enough. There was change in the iridocorneal angle before and after treatment in the same eye, but it was not that statistically significant. When we compare this parameter, when we compare the central corneal thickness with the unaffected eye and the healthy control, we also found a similar value. It was statistically different compared to the other eye or compared to the healthy eye of the healthy person. Hence, what lessons did we learn was, yes, the specular microscopy, the iridocorneal angle, and the corrected intraocular pressure, they could be the markers in managing anterior uveitis, because we all know the increased corneal thickness is an indicator of endothelial dysfunction, which is shown by the altered endothelial count and the change in the hexagonicity. When there is failure in the endothelium, this leads to the corneal hydration. This causes the increase in the corneal thickness, but that corneal thickness reverses and come back to its state after the treatment. Hence, the endothelial cell count and the central corneal thickness can be an essential biomarker to assess the progression and treatment outcome in cases of acute anterior uveitis. Similarly, for the corrected intraocular pressure, we all know that the standard technique for intraocular pressure measurement is the Goldmann applanation tonometry. But this is standard only if the corneal thickness is 520 micron, because that's a normal CCT in a general population. If there is change in the normal corneal thickness, that is an average error of 0.7 millimeter per 10 micron deviation can occur if there is a change in the corneal thickness. Hence, applanation reading is low when the corneal thickness is below normal, and this can give a false negative IOP. Similarly, the applanation reading will be high when the corneal thickness is above normal. Thereby, the pressure that is shown high could be false positive, and we might be tending to start the anti-glaucoma medication without taking consideration of this corneal thickness. Thereby, if we have a consideration of this corrected IOP, we can prevent the patient from the unnecessary use of anti-glaucoma medication. Hence, calculation of corrected IOP in regards to central corneal thickness and monitoring its change could be a vital marker in acute anterior uveitis. Finally, the iridocorneal angle. Yes, the inflammation of the iris leads to the swelling, which can cause the decrease in the iridocorneal angle. Moreover, we definitely have the formation of synecia, either in form of posterior synecia, leading to the seclusion or occlusal pupillae that may push the iris forward, causing the iris bombay, and the peripheral anterior synecia can pull the diaphragm forward, leading to the shallowing of the angle. But if we can assess this on time, we can prevent from untoward complication. Thus, iridocorneal angle can be narrow in eyes with acute anterior uveitis, and if we are able to control the anterior chamber inflammation and release the synecia, this can lead to the normalization of the angle. Hence, monitoring of the iridocorneal angle could be an important clue in the improvement of uveitic activity, and therefore should be considered another important biomarker for acute anterior uveitis treatment. So my take-home message is central corneal thickness measurement, the endothelial cell morphology study, and the corrected IOP measurement, along with the iridocorneal angle assessment, can be important biomarkers for evaluating the disease progression and treatment outcome in cases of acute anterior uveitis. If we ignore these biomarkers, chronic endothelial decompensation and long-term rise of pressure or fall of pressure can lead to irreversible uveitic complication. However, timely study of this biomarker can monitor the progression of disease and prevent from untoward ocular morbidities. I thank you for your patience hearing.
Thank you, Dr.